Connective tissue disorder, systemic lupus erythematosus, dermatomyositis, and scleroderma are the topics which are going to cover in this particular video. Hello dear students, myself Dr. Maddineni Srinivas, dermatology faculty from Bharat. Let us begin the discussion without any further delay. So first topic which we are going to cover is the lupus erythematosus. So what is this? So all these conditions are autoimmune conditions in which lupus erythematosus is autoimmune connective tissue disease which is characterized by the circulating autoantibodies which are going to mainly target the cell nuclear antigens, and the key diagnostic test which you can remember is the Lupus Band Test. What is it? It is demonstration of the granular or the linear deposits of the IgG, IgM and the complement C3 at the dermoepidermal junction basement zone on the DIF. And I will ask you a question on DIF in the pemphigus vulgaris, what is deposited and where is it deposited? If you know the answer, put it in the comment section. At the end of this video, I will tell the answer. Coming back to the SLE, so most sensitive antibody is ANA and most specific antibody for SLE is anti-Smith autoantibodies. So coming to the clinical spectrum of the lupus erythematosus, though we are discussing SLE, there are other types of lupus erythematosus which you have to remember. So purely skin, if it is affected, we have this discoid lupus erythematosus, which is also called as chronic cutaneous lupus erythematosus. And if systemic features are predominant, then we call it as SLE. And in between we have this subacute cutaneous lupus erythematosus. So we are going to see the features of each of them one by one. So in the DLE, discoid lupus erythematosus, well-defined coin-shaped or discoid plaques are going to be present with central atrophy. And in this DLE, remember, it's skin predominant and scarring is very prominent feature in DLE, and also it can produce the hair loss which is going to be irreversible, that is scarring type of alopecia can also occur in the DLE. And important signs are there which were previous year questions. So Carpet-tack sign, it is the hard keratin plaques which are going to be seen underneath the scale when we remove the scale from the scalp or the face lesion, and this is also called as tin-tack sign or cat tongue sign. All these are very important to remember. Shuster sign, scarring DLE lesions if they are present in the concha, it is called as Shuster sign. And if you see the antibodies are often ANA is positive in very low titers and dsDNA is often negative. Coming to the CCLE, cutaneous lupus erythematosus, it is going to present as annular polycyclic or a papillosquamous disorder. So it is going to mimic psoriasis, we can say. And in these patients, there is going to be non-scarring lesions and healing is going to occur with dyspigmentation. It can be having both hyperpigmentation as well as depigmentation, and there is no scarring. That is important to remember. And the patients are going to have photosensitivity. It's a very important symptom. That's why lesions are going to predominantly present on the photo-exposed areas. And it is strongly associated with anti-Rho or SSA antibodies. There are other conditions also which are associated with anti-Rho, anti-La antibodies which you might have read in other medicine subject. So as an integrated question, I am asking you what is the disorder. If you know the answer, put it in the answers comment section. I will tell you the answer at the end of this video. Coming to the SLE, it is also called as acute cutaneous lupus erythematosus. The classical lesion in this is the butterfly rash, the Malar rash, which is a fixed erythema present over the cheek and also over the nasal bridge. And the important interesting feature is this Malar rash is not going to affect the nasolabial folds. So it's going to spare the nasolabial folds, and it is also going to produce a non-scarring rash. And in the SLE, systemic lupus erythematosus, there are going to be other systemic features which are very important. The other site which have to examine is the palatal ulcers, which are going to be painless ulcers, right? And of course, the anti-dsDNA is a hallmark specific, highly specific, and correlates with the disease activity and also renal involvement in the case of the SLE. But remember, what is the most specific antibody which we have discussed? It is going to be the anti-Smith antibodies. And what is most sensitive? It is the ANA. So that's why in any patient where we suspect the CTD lupus erythematosus, we are going to send the ANA profile first, right? Coming to dermatomyositis, so there is going to be skin involvement and also there is going to be muscle involvement. The basic problem here is complement mediated microangiopathy, and this is going to affect the blood vessels which are present in the muscle and also in the skin. So intramuscular blood vessels and capillaries are going to be affected, leading to ultimately the ischemia of the muscle, and also skin damage will be seen. And also, if this dermatomyositis is seen in the adults, then we have to suspect a possible paraneoplastic association. So we have to investigate and rule out any internal malignancy in these patients. In the investigations, the creatine kinase is going to be elevated muscle enzyme, which is very important to look for in the question in the clinical vignette they may give, or in the options also they may give. The cornerstone of the treatment is going to be the high dose of oral corticosteroids. And most important in dermatomyositis is to remember the many named signs which are there associated. We are going to see them one by one. Gottron's papules. So the color in dermatomyositis which you have to remember is violet. So violaceous, scaly, flat-topped papules typically which are found over the extensor surface of the joints. And what are those joints? They are the MCP and PIP joints. These are what are called as Gottron's papules. And if the same areas are having just the violaceous macular erythema, we call it as Gottron sign. Heliotrope rash, a violaceous purple tinged macular erythema or the periorbital area or the upper eyelids. This is what is called as the heliotrope rash, and it could be even associated with the periorbital edema also. Shawl sign, the same violaceous macular erythema, if it is present over the shawl area or the upper back, we call it a shawl sign. The erythema, if it is present over the exposed, photoexposed area, we call it as V sign. Holster sign, the lateral aspect of the thigh having violaceous macular erythema is called as Holster sign, and these patients can have this hyperkeratotic changes of the palms. It is called as the mechanic's hands. Coming to the facial rashes, which may be very important, close differential. How can you differentiate? This table is going to help you with that. Dermatomyositis, SLE and rosacea. So we will see them one by one. Dermatomyositis, SLE and rosacea. So one feature at a time, we will see color and quality in dermatomyositis is going to be, like I have told you, violaceous or purple color. And this purple color is important in various other conditions in dermatology. So do you know what is that sarcoma? Very important previous year question, which can produce violaceous or purple color lesions over the body and also in the mucosa. If you know the answer for this, please put it in the comment section. Often it's going to be slightly scaly. Coming to the SLE, it's going to be red in color, erythematous rather than a purple or violaceous in color, and it is fixed erythema. Rosacea, acne rosacea, due to the abnormal vascular reactivity, this condition is going to occur, where there is going to be initially transient flushing, or we commonly call it as blushing, but ultimately there is going to be fixed erythema which is going to develop in the rosacea. Distribution in the case of dermatomyositis, it's going to be periorbital area, like I have told you, heliotrope rash. Whereas in the case of SLE, it is malar area, bridge area of the nose, and sparing of the nasolabial folds is characteristic feature. Butterfly rash. Here the central part of the face, the cheeks, the nose, the forehead and chin can be all affected in rosacea. The key associations, of course, definitely this is going to differentiate all these feature, all these conditions very easily. Proximal muscle weakness is very important in the case of dermatomyositis. If you investigate, we are going to see the elevated creatinine kinase. In SLE, there is going to be photosensitivity. Of course, this photosensitivity can also be there in rosacea, but important differentiating point is the ulcerations, the palatal, oral ulcers which are painless are going to be seen in the patients of SLE. Apart from that, obviously, systemic organ involvement is seen in SLE patients. Rosacea, that important point is triggers can be there given in the question. Spicy food, the stress, the heat, alcohol intake, all these could be present, and it can also present with papules and pustular lesions, and also eyes can be affected in the patients of rosacea. So these are all the easy points to differentiate between these three conditions which can present with erythema over the face. Coming to the scleroderma, systemic sclerosis. The basic problem here is the skin is going to become thickened because of the excessive collagen deposition. The main reason for this is dysregulation of the fibroblast. This is going to be the reason for all these changes, where ultimately the skin is going to become hide bound or bound down feel will be seen in these patients. If you are liking these type of videos, or if you want them on a regular basis, please do that like button so that I will understand that students are loving these videos. Let us continue the discussion. Key clinical features of systemic sclerosis is going to be the mask-like face. So wherever the skin is there, it can become hide-bound like skin, thickened skin. So expressionless face, mask-like face can be seen. Pinched or beaked nose can be there, and the mouth can be very difficult to open. So microstomia. And hands can have this sclerodactyly, that is thin tapering and thickened fingers can be there. And obviously Raynaud's phenomenon, very important for you to remember. Whenever there is contact with cold temperature water, then there is going to be what happen, three changes will be there, color changes will be there. Initially the skin is going to become white in color, later on there will be blue and followed by red colored changes. These three we call it as Raynaud's phenomenon. And of course if this Raynaud's phenomenon is happening on a regular basis, then it's going to lead to the ulceration and ultimately scar formation of the digits. Salt and pepper pigmentation is very important point, where the depigmentation and hyperpigmentation will be juxtaposed at the same site. This is what is called as salt and pepper pigmentation. And in the patients of systemic sclerosis, nail fold capilloscopy is very important investigation, where there will be dilatation with or without any dropouts. Coming to the classification of the scleroderma, we have this localized scleroderma which is called as morphia, very important morphia. This was previously asked many times. And systemic sclerosis, limited cutaneous SSC and diffuse cutaneous systemic sclerosis. So first let us look at the morphia. So here only the skin and subcutaneous tissue will be affected, there will not be any organ involvement. It starts as a violaceous indurated plaque which will ultimately heal with ivory white lesion. And remember, there is a linear forehead variant of the morphia which is called as N coupe de Saber. Okay. And autoantibodies usually will be negative in the case of morphia. And histopathology is very important. Box-like or rectangular appearance of the dermis is going to be seen on gross specimen on low power biopsy due to the squared off dermal sclerosis. Very important previous year question which you have to remember. Coming to the limited cutaneous systemic sclerosis, skin thickening will be seen distal to the elbows, knees and affect the face. Okay, and here we can see crest syndrome association, which stands for calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and finally we have this telangiectasia, that is dilated blood vessels, which can be seen in these patients. Organ involvement could be mild or late organ involvement can be seen. Pulmonary hypertension can occur in these patients. The antibodies, autoantibodies which you have to look for are the anti-centromere antibodies, and the microvascular damage, it can cause luminal narrowing and the ischemia in the histopathology. Right. Coming to the diffuse variety, here the involvement is going to be very extensive. Even the distal and not only that, proximal to the elbows and knees, the skin can be affected, and also the trunk can also be affected in these patients. Right. And rapid progression with severe systemic organ involvement is very characteristic feature of this diffuse variant. And the patients can have pulmonary fibrosis. And remember, the most common cause of the death in these patients is ILD, interstitial lung disease. And of course there can be renal involvement also in these patients. And the autoantibody which you have to identify is anti-topoisomerase 1 or anti-SCL70 antibodies, and there can be widespread fibrotic process. Coming to the note or treatment which we can say in the patients of the systemic sclerosis, methotrexate is a commonly chosen disease modifying agent for progressive skin fibrosis. And the Raynaud's phenomenon we can take care of with the help of calcium channel blockers, that is nifedipine, okay, which are the first line systemic therapy. So I hope this video is helpful, so please like button, and also do comment if you have any doubts, and do subscribe to the channel if you are liking the content of dermatology on a regular basis which is shared in this channel. So we'll meet again soon in the next video. Happy learning. Sarvam Sri Krishna Sarvejana Sukhana Bhavantu. Before that, I just want to tell you the answers for the questions which I told, asked you in the beginning. So what are those conditions where the violet color can be seen in the skin? Kaposi sarcoma. And of course even the lichen planus, the skin is going to have violaceous or purple color lesions. And before that, when I asked you one more question, DIF is going to show in the patients of empicus vulgaris the deposition of the IgG and C3 in a fishnet or chicken wire pattern in the epidermis. And let us also quickly cover the other ones. In the bullous pemphigoid, what is going to be there? The same IgG and C3 can be there at the dermoepidermal junction. And what is the pattern here? It's going to be linear pattern. Coming to linear IgA disease, here the deposition is going to be IgA, right? And what is the pattern? It is obviously going to be linear again at the dermatoepidermal junction. In the case of dermatitis herpetiformis, what is going to be deposited? It's going to be IgA, but now it's going to be deposited at the dermaepidermal junction and also at the papillary tips, and it's going to be in a granular fashion. So this is how you can just quickly memorize, revise all the previous topics in the subject, and also you can integrate with other subjects also. So that's it. Thank you so much. Happy learning. Sarvam Sri Krishna Sarvejana Sukra. Bye bye.